Economic evaluation is normally used to maximize health in situations where we have a number of alternative interventions and in situations where the budgets or resources are limited. The first question we ask is whether the implementation of one intervention will affect the implementation of alternative interventions. If the answer is no, we have a situation where interventions are independent. If the answer is yes, we have a situation of mutually exclusive interventions. So let's talk about independent interventions first. In these situations, the interventions can be implemented simultaneously in the same population. That can be done because they don't affect each other. And in this situation, we consider average cost-effectiveness ratios. And you see the formula, it's simply the cost of the intervention of the effectiveness of the same interventions. The decision rule goes like this. When we have a fixed budget and a list of independent interventions, we first calculate the ACERs. We then sort the list of interventions according to increasing ACERs. So the ACER, the intervention with the smallest ACER goes on top of the list. Then we calculate cumulative costs and effectiveness of introducing the ACERs, introducing the interventions one by one. And remember, we can implement as many as we want, or as many as we can afford of these interventions, because they are independent. And finally, we add interventions from the top of the list until the budget is exhausted. Sometimes we can afford only one of them, and other times maybe we can afford all of them. And they can be implemented at the same time because they are independent. This is somehow a special situation. The most normal decision problem in applied economic evaluation is about mutually exclusive interventions. In these situations, only one of the interventions can be undertaken at the same time and for the same patients. And when this is the situation, we consider the incremental cost-effectiveness ratio, which is the difference in costs between two interventions divided by the difference in their effectiveness. And you see the formula. This gives us a different decision rule. So first, we sort interventions according to their increasing effectiveness. So on top of the list, we have the least effective intervention, the one that produces the lowest health gain. Second, we calculate the ICERs. 3, we exclude all dominated alternatives, and we will talk more about dominance later. 4, we recalculate the ICERs and repeat steps 2 and 3 until there is no more dominance. 5, we select the most effective intervention within the willingness to pay threshold. Let's look at this graphically, and we can use a cost effectiveness plane for this, where we put costs on the y-axis and effectiveness on the x-axis. Usually we put the comparator as the current intervention, and we put it in the origo, and then we compare intervention alternatives to this one, and they can be more or less costly and more or less effective in this way compared to current intervention. Sometimes the decision is really easy. If the new intervention is less costly while also being more effective, that is two good situations. the new intervention dominates the comparator, and it's a green light. The decision to change from the old one to the new seems pretty easy to make. Inversely, if the new intervention is more costly and less effective, the new intervention is dominated, and there's no reason to spend more money to receive less health. So it's a red light. But in these other corners, the northeast and the southwest corner, we are less clear. So we need to consider how much we are willing to pay to improve health. And this is considered by a so-called cost effectiveness threshold, or a willingness to pay threshold for health. This threshold is a measure of how much we are willing to pay as a society to achieve health gains. Once we know the cost effectiveness threshold, it's easy to make our decision, because whatever falls below and to the right of the threshold can be considered cost effective. We will talk more about the threshold later. Now we will discuss the concepts of dominance and extended dominance, which are important for our decision making. Dominance is the situation when the cost of an intervention rise while the outcome decrease compared to another intervention. These are the northwest and southeast solutions in the previous diagram. We can also consider them in a graph like in this one, where we have intervention A and intervention B, and we see that intervention A is more costly and less effective compared to B. So in this case, we can say that B dominates A. Or inversely, we can say that A is dominated by B because it is more costly while being less effective. Extended dominance is slightly more complicated but very related to dominance. Consider these three alternatives, A, B, and C. The definition is that when a linear combination of two strategies produce greater effect at a lower cost than some other strategy, then we have extended dominance. What does this mean? Okay, let's consider a combination of A and C. That means we give A to some patients and C to some patients. This is a linear combination. In this case, we see that B is ruled out because of extended dominance by A and C. So for a certain sector of the linear combination, B is more costly while also being less effective compared to the combination. So this is dominance. So in this case, we provide either A or C, or we provide A to some patients and C to other patients. It depends on the budget. How much can we afford? So there are two conditions for this approach. First, that the treatment options are perfectly divisible and that there are constant returns to scale. So there are not economies of scale of giving only A or only C. How can we detect the extended dominance? There are two approaches. There is a numerical approach, and that's when the incremental cost effectiveness ratio, or the ICER, for a certain treatment is higher than the one of the next more effective alternative. Alternatively, graphically, when the line connecting the sorted interventions becomes concave, And you can see the concavity here when we connect the sorted interventions like this. And you also see that the line connecting A and B, this ISER is steeper, so the ISER is higher than for the next and more effective alternative. So this is the numerical interpretation. Okay, now we're going to talk about the choice of comparator. Choice of comparator is very important and can very much affect the outcomes of an economic evaluation. There are basically two main approaches. There is the so-called intervention mix constraint cost effectiveness analysis. Consider this graph where we compare the existing intervention A to three new alternatives B, C, and D. And you see how the ISERs are increasing in this situation. So in this case, the choice between A, B, C, and D will depend on our willingness to pay. They can all be relevant options. So the possible question we can ask using this analytical approach is, how should we use an extra unit of money? Now, the other approach to this is to do a so-called generalized cost effectiveness analysis, where A, B, C, and D are compared to the null intervention. So now we assume that it's possible to do nothing, to forget about A that we are currently doing and compare with nothing, the null intervention. Now, the possible questions are broader. We can ask, are we using existing health budgets as well as we could? Or should we stop doing something in order to do something else? And how should we use an extra unit of money? So you see, there are more analytical scopes of this approach. So when we do this, the generalized CEA, we actually realize A and B are dominated alternatives and they shouldn't be considered good use of existing health budgets. So actually, the only cost-effective alternatives are C or D. Now, we talked about willingness to pay thresholds or cost-effectiveness thresholds. How can we consider this? What is, how much should we be willing to pay? There are basically four approaches: the rule of thumb, league table, revealed, or stated preferences methods. Rule of thumb method is by far the most common to see in the applied literature. One of the earliest ones was in the US by Kaplan and Bush, that considered an ISO less than $20,000 per well year. This was early days of the discipline, so the quality wasn't well established, but roughly a well year is the same as quality. So less than 20,000 is considered cost effective. When the ISO was in the range 20 to 100,000, it was possibly controversial but justifiable, but questionable for higher ISOs than 100,000. The NICE have quite firmly established these thresholds in their decision making for the UK. So below £20,000 per quarter is considered cost effective and new interventions should be implemented. When the ISO is in the range 20 to 30,000 pounds per quality, some additional arguments are required, and when the ISO is higher than 30,000 pounds per quality, the additional arguments need to be strong. World Health Report 2006 suggested a similar approach, that ISOs below 3 GDP per capita per DALI, disability adjusted life year, is considered cost effective, while when the ISO was lower than 1 GDP, it was very cost effective. This has been quite influential for the low-income economic evaluation literature. Okay, league table approach. Consider the example of maximization of health based on independent intervention. It's assume you can do the same for all health interventions in one society, which is pretty impossible actually, to be honest. So we do this and we start implementing from the top of the list, and then we stop when the resources of the society for healthcare have been exhausted. And where we draw the line, that is the cost effectiveness threshold. And this has never been done. Revealed preferences is when we observe actual decisions and actual priorities. And then we see what are the implicit willingness to pay thresholds for those actual decisions. And that could also be considered normative for future decisions. So those are revealed preferences. This graph is from a paper we wrote based on Norwegian data. And the data suggests that willingness to pay is much higher when the number of users of certain drugs is small. And when the number of users, when the patients are few, the budget implications are not so high. But when the number of users are high, willingness to pay seems to go down because the budget impact was high. Finally, stated preferences is about asking people how much they think society should pay for certain health improvements. This can be done through choice modeling or through contingent evaluation. It is also not very much used. So actually the common approach is the rule of thumb approach, where certain thresholds are suggested.